So I'm 1 minute late because Facebook made me title this video. Um, so you notice I have no sunshine during this little broadcast. It is rainy and thunderstormy. It's been doing it. I've been up since 3:30, so it's been raining and lightning and all that for a while. So what we're going to talk about today is testosterone. I've thrown that little hormone around for a little while. I bring it up a fair amount, and just like the progesterone thing I did last Friday, I realized, well, I haven't really taught anybody anything about testosterone, even though I talk about it a lot. Hi, Eileen. So testosterone is one of the androgens. So everybody calls it a male hormone. Well, guess what? Women have testosterone as well. They can also have testosterone deficiency. And in my little blurb that I put up at 8, I said there's a difference between testosterone deficiency and suboptimal testosterone. So I talk to people all the time who said, well, I had my testosterone levels checked and my doctor said they were normal. And so there's that. And that's as far as they get. So why I said that 99% of physicians don't seem to get that is because they don't get that. And I've been doing hormone replacement and balance really since 1988. Hey Linda, hey Wendy. And I have a little protocol. It's mine. It works for women. It works for men. Hi Linda. And at one point in 2013, I became the medical director for the Oklahoma Men's Clinic in Tulsa and got the owner to open an Oklahoma City branch. And he didn't think he needed to do that because he said, well, everybody from Oklahoma City will drive to Tulsa. And I said, no, they won't. I said, Tulsa and Oklahoma City is like St. Louis and Kansas City. Never the twain shall meet. So Oklahoma City wound up being an actually busier office. But I wrote the protocols for testosterone replacement for the Oklahoma Men's Clinic. And they're still open, and I'm sure they're still using my protocol. That was for men. It was the men's clinic. However, women's testosterone replacement I've been doing for years and years and years. And so here's the difference. And I teach this to people all the time. They get it. It makes perfect sense. So you have to think, when you're dealing with hormones, about a bell curve or the Gaussian distribution. You learned it in high school. Morning, Sarah. So the bell curve, it's the way grades are done. So A, B, C, D, F. And typically, if you're under 60%, you get an F, right? You can also do anything. You can measure anything, and it'll follow a Gaussian distribution curve. And I'm going to explain how I think about hormones, and I'm going to steal 2 examples from a nurse practitioner that I don't know, but I've read her book, and she explained it very well. So testosterone is a performance hormone. It's like the gasoline for your body. So I talked to somebody yesterday, and I said, okay, think about your thyroid as an accelerator, and your testosterone is the gasoline. So if you have a faulty accelerator, even if you have good gasoline, you're not gonna get the performance you want. And if you have a good accelerator and you have yucky gasoline, you're not gonna get the performance you want. So that's a car analogy. Okay, so the Gaussian distribution goes from 2.5 percentile to 97.5 percentile of a population. So whatever you're measuring, 95% of the population will fall between those 2 percentiles. Okay, so here's the analogy. So I got a women's one, and a men's one. So for women, this is from the nurse practitioner. Let's say that I worked in a bra store or a shoe store. So women get this. So Let me get a drink here. So if I work in a shoe store, so let's say I'm the married with children guy, and the average shoe size worldwide for women is 8. And the Gaussian distribution, normal, is 4 to 12 shoe size for women. So let's say you come in and you tell me I have a soiree to go to and a dance. Friday night, it's Wednesday, and I need a new pair of shoes, and I like this shoe, and I wear a 7.5 shoe. So if I'm an unethical guy, I go to the back and I have a 7 and I have an 8, but I don't have a 7.5. So if I take the 8 back to you, it'll fit. But if you buy it and you go to your soiree, you're going to realize that the shoe is too loose. It's brand new. It may fit, and you think it fits, right? And let's say I think, okay, well, she wears 7.5. I'll try the 7. I can probably stuff your foot in a 7. But if you buy the shoe and you go to a dance, you're going to be mad at me. That's the way you have to think about hormones. They fit you. And the job of a hormone replacement person, nurse practitioner, doctor, health coach, whatever, health coach working with doctors, which is what I do, is to find out where that fits. So we're looking for a shoe fit. The other one is bra cup size. So if I was selling you bras and I sold you the wrong cup size, you would bring the bra back because it doesn't fit right. I don't know what that feels like. I know what goofy shoes feel like. Of course, I don't know what a bra cup misfit it feels like. Testosterone, among all the other hormones, is the same way. Okay, so that's the women's analogy. That's from a nurse practitioner. The men's analogy is performance. So athletic performance, job performance, sales, whatever you want to do, it follows a Gaussian distribution. So let's say I'm a car salesman. And at the end of the year, my manager comes to me and says, well, Brian, for performance this year, you came in at the 12th percentile of all the salespeople. And we're not going to give you a raise or improve your commission. You're going to have to work harder. So that's a performance thing. So if you're at 12th percentile as a salesperson, you're probably not going to do very good. As opposed to a person that the manager comes and says, okay, well, you came in the 92nd percentile of sales this year. We're going to bonus you and give you a better commission, et cetera, et cetera. So that makes sense to men. Performance, athletic performance is the same way. Not everybody is Michael Jordan. He's in the 99.9th percentile of professional basketball players when he played. Not all the NBA players or college players are of that caliber. And the ones that get cut are on the lower end of the curve, correct? Does that make sense? So they don't make it. Okay, hormones, again, same way. So if we talk about grades, shoe sizes that don't fit, bra cup sizes that don't fit, or poor performance, then you're starting to get how I think about hormone levels. So we're going to focus on testosterone. So we're going to talk about men first. And depending on the lab, so you got to remember Gaussian distribution, bell curve. So when a lab tells you what their normal results are, they're giving you that 95 percentile of the population of the blood tests that they've done in their lab. I'm going to tell you the textbook. Okay, so every lab's different. So the textbook definition for the 95th or 95% of total testosterone levels in males is around 250 to 1180 picograms per deciliter. So if you go to the doctor and you have low T symptoms, and I put that Adams score up for both men and women to score themselves. If you score 3, your testosterone doesn't fit you. I don't care what your level is, it doesn't fit you. So let's say you have, you're a guy, you have some erectile dysfunction, you have a low libido, which those two right by themselves tells you, for men and women, if you have a lower sex drive, your testosterone doesn't fit you. Just that one question. But let's say that so a guy goes in and says, well, I've got a less firm erection, my sex drive has fallen, and I fall asleep after dinner. So let's say he's got a 3, okay? So the doctor says, oh, okay, so we'll just check your total testosterone level. And it comes back 251. And I just told you, so most labs, the lower limits of normal is 250. So the guy has a 251 total testosterone. And we'll talk here in a minute about free testosterone. That's the active hormone. That's the bioavailable hormone to a person's body, male or female. So the doctor would say, well, you're in the normal range, so can't help you. I hear that story every man I talk to. I've had that story told to me probably 4,000 times. And that's since 2013, because I didn't take care of men before 2013. Okay, well, that gets you an F if you're on the grade scale, right? You're 251, you're normal, technically. Well, not really. So testosterone, really, to be effective, usually for a man, 800 to 950. There is a company in Las Vegas. They're pretty famous. They've got a famous doctor as their spokesperson, used to own the company. And they put everybody at 1,200. So they would replace testosterone for men to 1,200. I don't think every man needs that. So that's just kind of dumping everybody in the same boat. So if you got a guy that has no symptoms and a testosterone of 300, he's fine. His body runs on that amount of fuel, so to speak. So if you think about testosterone as gasoline, so an asymptomatic man with a lower limits of normal testosterone is fine. I've also seen men, lots of men, that have a testosterone, let's say 400 to 600, but they have 8 out of 10 of those questions, they're symptomatic. Their testosterone is suboptimal. So you don't give them the same dose. So the individualization of hormone replacement is so important when you do this for a living. Everybody has a fit, just like your shoes. Okay? So let's say I got a guy that's 450, he's got 8 out of 10 on his Adams score, and I give him a smaller dose of testosterone. Let's say he's 52, and I give him a smaller dose of testosterone and get him to 850, and all of his symptoms go away within 3 months. Then I got to figure out how to keep him there, and I have to monitor him. Cannot begin to tell you how many men that are on testosterone that come in, or I've talked to, and I'll say, when's the last time you had a testosterone level? And they'll say, oh, a year or 2 ago. Well, that's not how you do it. You've got to monitor guys. So men that get in trouble, all the commercials you've seen from lawyers and, oh, it's going to do this, heart attacks and stroke and prostate cancer and all that, those men were probably not monitored. So you have to talk to them. I talk to them every 10 to 12 weeks. I make them do their labs. We adjust their testosterone replacement so that we can get them as close and maintain them at the testosterone level that fits them. That's how you do it. More importantly, I follow free testosterone. So free testosterone is what's actually working. Okay? So total testosterone would be like if you had an extra gas tank on your pickup truck, which I've seen a lot of guys do, and when they run low, they can turn on that other gas tank. That's total testosterone. What's in the gas running the truck is free testosterone. And typically you want to see men over 12, if not 15, ideally 18 to 22, high normal, so that Gaussian distribution for free testosterone almost in every lab is 4.5 to 25. So you get a guy up to about 20 and he feels like he's 35 years old. So all those Adam score thingies, they say, yes, I have this and I have that, go away. Doesn't always work for erectile dysfunction, but it's a first good try, because you can put people on Viagra and Cialis and give them erectile dysfunction. It's on the box. Just read it. This will cause erectile dysfunction over time. So testosterone replacement is a good start for the 10 things that are on the Adam score. So the idea is to get a guy where a man where where his testosterone level fits him. And that's typically going to be in the upper quartile of that 250 to 1170. So 900-ish. Okay. So let's talk about all the lawyer things. Testosterone cypionate was put on the market in 1939. When I was in medical school in 1982 through 86 on my urology surgery rotation, Dr. Weinstein, who's still at the University of Missouri School of Medicine, was taught that testosterone raises the risk of prostate cancer. That's the first question men that have never done it will ask. They'll say, well, doesn't this cause prostate cancer? Well, that question was put to rest over however many years that testosterone's been used. The prostate cancer risk comes out of one guy who got prostate cancer on testosterone, and they published a paper on that guy in 1941, and everybody's drank that Kool-Aid for all these years. My urology buddies, I'm going to say 3-4 years ago, started preaching kind of what I'm telling you. They say, well, testosterone doesn't cause prostate cancer, but if you have one, it'll grow it faster. I totally agree with that statement. The urologist that I worked with in Oklahoma City, I called him one day and I said, I'm going to ask you a question, and the answer is yes or no. You can't expand on your answer. And he said, okay, I'll play that game. I said, testosterone cancer causes prostate cancer, yes or no? And he said, no, but. And I said, shh, quiet. And he said the same thing. But if you have an indolent prostate cancer that you don't know about, it will grow it faster. Totally agree with that statement. There's a guy at Harvard, Abraham Morgan Taylor. I've heard him speak twice. He's a urologist, sexual health guy, and he does prostate cancer treatment. He did a study in 1988, published. You can look it up. It's Abraham Morgan Taylor, Morgentaler. He has a website talking about testosterone. In his study in 1988, how he did this, I don't know, and I can't remember the N number if you know statistics. I'm going to say several hundred men that he talked into having a baseline testosterone level and having a prostate biopsy. That's not on my bucket list, but he talked these guys into letting him biopsy their prostate gland. What he found, and you can look the paper up, it's right on his website. He found that men that are under 60 years old with a total testosterone level of 350, well, we'll say less than 350, so in that lower normal range, 15% of those men had aggressive, asymptomatic prostate cancer. So they got treated. He believes in testosterone replacement. So to reduce your chance of prostate cancer. He believes it so much that if he's treating you for prostate cancer, he puts you on testosterone. He uses androgel, which is really expensive. So his conclusion, and then of course he had men that were over 60, but his conclusion was the aggressive kill guys' prostate cancer, the guys that have to have robotic prostatectomy, and then they have erectile dysfunction, and they lose their urine, and they have no feeling in their penises and all that, because they have to strip nerves out to do that. The risk of the risk of prostate cancer in men under 60, the aggressive, nasty kind, is a total testosterone level less than 350. He published it. And then he's been preaching it now for 32 years. He's still in practice. If you get to the age of 80, because most men over 60 are going to have they have testosterone deficiency. So their testosterone is usually under 250. So there's a second type of prostate cancer that's from that affects older men. And by the age of 90, they know this from autopsies, 90% of men by the age of 80 have prostate cancer and they don't know it. Okay? So that's the story on prostate cancer. All the literature, and you can go back to the 60s, about heart disease and stroke and heart attacks are found to be related to low testosterone levels. You do have to monitor, and the monitoring includes checking the amount of red blood cells that are in whole blood. Testosterone will increase red blood cell production from the bone marrow because your body is getting this fuel and thinking, oh, we need more oxygen carrying capacity. So some men have to donate blood every 3 months. My internal medicine doctor from St. Louis thinks all men should donate blood every 3 months just to get rid of iron stores, because men tend to have more iron than women. Okay, so you can get a guy in trouble, but it's not from testosterone, it's from lack of monitoring, laboratory analysis, and talking to the man. If you're going to treat them, you have to treat them and monitor them. Now, I have taken men off of testosterone because their blood got too thick and told them, well, we need to fix this. And I've taken men off of testosterone. I've never had a guy have a heart attack, and I've never had a man that I was monitoring that got prostate cancer. I screen them before we start because you remember my urology buddy said, well, if you have an indolent, meaning they don't know they have it, prostate cancer, you can grow it with testosterone. So you have to screen them. Pretty simple. You do a baseline thing. So PSA analysis, prostate-specific antigen, should be less than 4, and then you have to watch to make sure that it doesn't go up. And if it goes up, you stop the testosterone, you have them see a urologist. So monitoring, talking to, listening to what they say, asking the right questions, that's how you monitor a man on testosterone, keep him out of trouble. It's a safe thing to do. You don't blast them into the stratosphere with testosterone levels, because a 60-year-old guy doesn't need the testosterone level of an 18-year-old. They run about 1,500. And I always told guys, if I got you that high, you'd get arrested. So there is a thing called roid rage. You've heard it, and testosterone is one of the ways to do it. The bodybuilders have used testosterone. They're taking, 200 milligrams every day. We give typically 100 to 200 milligrams. A younger guy, maybe 250 every 7 days. Some men, I'll split it and they'll do half their dose every 4 days. That's how you do testosterone replacement. Shots are cheaper. The research is on testosterone cypionate. So there's years and years and years of research on testosterone cypionate. Some guys do it with creams. Some guys do it with gels. What doesn't work in men is oral testosterone. That you can't get the dose high enough. So you have to inject it, or it has to go through the skin. Okay, so let's talk about women. So that's the guy thing. It's easy to do, but you do have to monitor. You have to talk to them. For women, that ADAM questionnaire stands for androgen deficiency in the aging male. I pretty much ask the same questions of women because they have the same symptoms if their testosterone level doesn't fit them. And then clitoral sensitivity. Okay, so a reduction in clitoral sensitivity is sort of the equivalent of erectile dysfunction. Not quite, but similar. And I remember when I was in Bolivar, so this would be back in the 90s, Oprah Winfrey had a show where women came on and were talking about their reduction in clitoral sensitivity and ability to have orgasm. And the ones that had been treated with testosterone gel got better. So I got like this huge voluminous amount of women coming in saying, can I have testosterone gel? And I said, well, not without a test. You got to fill out this questionnaire. So that works. Testosterone gel to the vulva improves testosterone and clitoral sensitivity and improves orgasmic function for women. But I don't think that you get enough testosterone necessarily through the skin. Some women do. So women, you can give them an oral testosterone dose in addition with their other hormone replacement. Or you can give them a booster shot, and we do that. I've done that probably 30% of women, where you just can't get the testosterone where it needs to be, so you give them an itty-bitty small dose intramuscularly. I call it a testosterone booster. And then they hold on to that because of body fat distribution for anywhere from 3 to 6 weeks. And most women, if they take a testosterone booster, they will tell you to the day when it fell off and they need another one. Literally, they'll say, okay, that lasted 23 days or 31 days or 38 days. So a testosterone booster for women that respond to that, 3 to 6 weeks, usually 1/4 the dose that you give a man, while you're giving them a daily testosterone replacement. Okay, so we monitor women the same way. The difference is the Gaussian distribution curve. So for a woman, and this is textbook, I just looked at a LabCorp lab yesterday on a woman who has a testosterone level of 32. LabCorp's range is 2 to 45. The textbook range in endocrine textbooks and reproductive endocrinology textbooks is 20 to 80. So for me, the goal is about 65. Free testosterone also comes into play. For women, it has to be bioavailable, and that range is 2 to 6. And LabCorp was 0.2 to 4.5. So almost the same as the 2 to 45. So you divide it by 10 for women. So the goal for a free testosterone level in a woman is about 6.5. And it's doable. You can get them there. It works all the time. It's like 100%. You can get there. And the idea is to set the level of testosterone not in the stratosphere. You're getting a woman back to the level she had when she was about 30. So if women think about their sexuality and their body image, and if you ask them, at what age did you feel the best about everything in your life, your marriage, your sex life, your whatever, your career, your motherhood, if you do that, they'll give you an answer of about 30. 25 to 35 would be the bell curve for the answer to that question. So in my mind, I always think, okay, I'm going to get this young woman or this older woman back to the level of a 30-year-old, which is you're not above the normal range. If you compare that range to, you got to remember, hormones fall after 40 for sure. They usually start falling at 30 for men and women. So if you compare a 60-year-old range on a 60-year-old, you're going to get a different range than if you compare a 60-year-old to a 30-year-old. And the decrease is considered normal, and those of us that do replacement of hormones don't agree with that. So it may be normal to lose your hormones, but lo and behold, if you get men and women's hormone levels back to a younger time, they actually feel like they did at that younger time. So that's the story on testosterone. It's not dangerous if you're monitored. You shouldn't take it if you have none of the symptoms. I don't care what your testosterone level is. If you're asymptomatic, it fits you. So the art of this and the science is to figure out, well, the science is replacement. How do you do that? The art of it is figuring out for a specific man or a specific woman, what shoe size fits. what testosterone level fits. And we can talk about all the rest of them as well, but this one's about testosterone. So don't be scared about testosterone. You just have to find a functional medicine doctor or like a hormone specialist type doctor or nurse practitioner that knows what all that means. There's plenty of them. Well, there's not plenty of them around, but they're around. And I know not all of them, but I know the ones in certain regions that would work with you on that. So that's it for today. Testosterone for men and women. It's not just for men. I've been doing this since 1988. So I'll talk to you Friday. I haven't decided what I'm going to do yet. If you got something you want to hear about, shoot me a DM or put a comment, and I'll research it. I had one yesterday that I really got to research if I'm going to do it, because I'm kind of out of my element. And it might actually be above my pay grade, because what she asked me to talk about, I had never, well, I kind of heard of it, but I didn't know the terminology. So if you want your hormones checked, Life Extension is still on sale until July 13th. So there's a male basic hormone panel and a female basic hormone panel, both of which measure testosterone. They're usually $75. They're $56 until July 13th. I'll put a link up for men and women. You don't need to go to the doctor. You just order it. They'll send you a kit. You take it to a LabCorp lab and have them draw your blood. And you will get the results in your email in about a week. Okay? So that's available and it's on sale, but it's only till the 13th. So I'll see you Friday at 9:30. And peace and health. Have a great day. See you later. Bye.